Very good evening to all our respected dignitaries of IMA members and the respected dignitaries of the Prathima Cancer Institution. Really, it is a great pleasure to have this evening with the Cancer Oncology and Surgical Oncology team, directors of the Prathima Institution, Warangal. And on behalf of IMA, we convey heartfelt welcome and thanks for the pains they have taken all the way coming from Warangal to deliver a lecture here. And we are all very thankful to you, sir. And at first out, Dr. Avinash Garu, a medical and surgical oncology, surgical gastroenterologist, and Dr. Rahul Maddi, medical oncologist. Now, at the very outset, I invite Dr. Avinash Tippani to deliver his lecture.
థ్యాంక్ యూ సో మచ్. నేను మహబాద్కి ఆల్మోస్ట్ 2014లో వచ్చాను. సో ఇట్స్ బీన్ ఆల్మోస్ట్ 9 years. థ్యాంక్ యూ సో మచ్ ఫర్ దిస్ ఇన్విటేషన్. సో రీసెంట్గా వీ హ్యావ్ స్టార్టెడ్ ప్రతిమ క్యాన్సర్ ఇన్స్టిట్యూట్ లాస్ట్ 1 year బ్యాక్. కేసీఆర్ గారు ఓపెన్ చేశారు. సో కొంతమంది మా హాస్పిటల్ చూసే ఉంటారు. సో దిస్ ఇస్ ద లొకేషన్. సో అందరిని ఒకసారి రిక్వెస్ట్ చేస్తున్నారు, యూ కమ్ టు ద హాస్పిటల్ అండ్ యూ సీ ఆల్ ద ఫెసిలిటీస్ వాట్ వీ హ్యావ్ ప్రొవైడెడ్. సో ఈక్వల్గా హైదరాబాద్, ఆన్ పార్ విత్ హైదరాబాద్, ఆల్ ఫెసిలిటీస్ ఆర్ దేర్. Oncology and gastro full-fledged. 50 beds of hospice and dormitory, linear accelerator, brachytherapy, PET CT, advanced CT, digital mammogram, and 7 operation theatres. And we have a full-time organs facilities. This is 60 personalized CT scan what we have in the hospital. So apart from that, we have a full state-of-art medical gastroenterology department with 3 radiations, ultrasound, ERCP, colonoscopy, and recently we have started even endobronchial ultrasound. So recently we have done 2 cases of ES. So that's the first time we have done ES in Warangal for all malignancies for the lung, because it is very tough to do a lung biopsy as such. So we regularly do screening. So we operate direct sections, silent glands, skin, direct tumors, and total and partial animal biopsy. And we are doing even pre-lab reconstructions also. So these are the few cases what we have operated recently. So this is the linear accelerator. This is the first state-of-the-art linear accelerator which delivers radiation to the patient. So we have radiation in the form of VMAT, IGRT, SRS and SBR. SRS and SBRT is mean stereotactic radiation, stereotactic radiation, where we can do precisely brain surgeries without operating the patient with the help of radiation. And this is the linear accelerator position, which is the electrical linear accelerator. And brachytherapy also we have. Brachytherapy is also first in Warangal. So routinely we use brachytherapy for treatment of malignancies of the cervix. And this advanced PET CT, this is also state-of-the-art PET CT, where we have chemotherapy technology, where we can do about 10 to 15 PET CTs per day, and the dosage we give is less than 5 million per patient. So we do very quickly PET CTs, and also the reporting is also extremely good. So very small lesions less than 1 millimeter can also be detected. So we have digital mammogram with stereotactic biopsy, where we can do a mammogram as well as we can take a biopsy from the breast tissue. Recent advances in all the malignancy, we are open to discussion.
Got cancer established. I have moved from Warangal to Warangal all the way to start practicing. So our journey started almost 12, 13, 14 years back in this, and right now we are doing very well in Prathima. Hopefully the thing goes for next 30 to 40 years also. The thing is, coming straight into the topic of medical oncology recent, I would like to finish in 10 minutes and we'll go for a small 5-minute discussion and we'll close it. Within 15 minutes, we can proceed with that in the cocktail dinner. The recent advances in medical oncology. What are these recent advances means? Usually, medical oncology means you all know that it is generally chemotherapy. So, other than chemotherapies also, there are many other treatments which are coming to picture. Now, these are called targeted therapies. So, the targeted therapies may be in the form of monoclonal antibodies, like many of your rheumatology colleagues and nephrology colleagues also know about that. So, these are these can be monoclonal antibodies or some other treatments which are usually called as small molecule inhibitors. And there are chemotherapies which are coming to picture now, which are called immunotherapies, which many of you have an idea of, and every patient in your family, in your friends' families, or in families get affected with malignancies. Definitely, you'll be hearing something about immunotherapy, and everybody comes to me asking for immunotherapies. So, what is immunotherapy? Immunotherapy is a treatment that uses a person's own immune system to fight cancer. So, immunotherapy can boost or change how the immune system works, so it can fight the cancer cells and attack them. So, what usually happens is in traditional cancer therapies with radiation or the chemotherapy drugs, they kill the cancer cells in multiple mechanisms, which is the other topic of discussion. But in the process of killing the cancer cells, the healthy cells are also destroyed. Therefore, there will be many side effects. In cancer immunotherapies, which is a kind of target therapy only, what we do is we increase the immune system of the cancer patient, therefore make the patient only fight the cancer, and therefore the patient he himself kills his cancer cells. So there will be hardly any side effects. For example, what we do is we try to detect a receptor on the tumor cells, which is called a PD-L1 receptor, and there will be husband and wife kind of receptor-like relationship with the PD-L1. This ligand is called PD-1. Such kind of ligands will be on the T cells. So when PD-1 binds with PD-L1, the immune system is deactivated. The immune system is deactivated and the T cell does not kill the tumor cell. So what we do is we give a drug which will bind to the PD-L1 and inhibits which blocks the attachment of PD-1 with PD-L1. So when this combination doesn't happen, T cell gets activated and it kills the tumors. So what we do is we prevent the binding of PD-L1 with PD-1. That's it. When this binding is blocked, the T cells get activated and they kill the tumor cells. There are multiple drugs, and a very famous drug is called pembrolizumab, which is very frequently used along with chemotherapy, along with the monoclonal antibody, and along with small molecule inhibitors, and they are used as single also. So Keytruda is becoming very popular drug. This is how Keytruda works. The PD-L1 is the binding of PD-1 and PD-L1 is blocked, therefore the immune system is activated. There is another drug by name Tacentric, which is called atezolizumab. This also acts in a similar way. Another drug by name nivolumab. These are majority used in academic cancers and malignant melanomas. This also acts in a similar way, blocking the binding of PD-L1 and PD-1. There are other drugs which are called durvalumab. This durvalumab is recently banned in India because the phase 3 trials were not successful. It was given an accident approval of phase 2 trial, and again after phase 3 trial, the approval was blocked and banned in India. This is another drug, an example of targeted therapy. MAB is monoclonal antibody. This daratumumab is will act against CD38 receptor, and we use it in multiple myeloma. So the cell detects whether there is CD38 receptor on the cells or not, and based on the presence or absence of CD38, it kills the cell. So how do we detect PDL1? We detect PDL1 by a method by name MUTS per MB. So that is called total mutation burden. More the total mutation burden of PDL1, more the activity. For example, if the total mutation burden is more than 50%, I won't use any other than immunotherapy. I just use immunotherapy, and the patient will have amazing response. So more the human mutation burden load, more the response to the immunotherapy. If the human mutation burden load is less, I have to combine immunotherapy with chemotherapy. If it is even more less, I cannot use immunotherapy. So this is something important for me to start immunotherapy. So as I already told you, monoclonal antibodies, multiple varieties of monoclonal antibodies available in the market. Cetuximab, which is used in colon cancer, rituximab is used by nephrologists, rheumatologists, and used by medical oncologists for lymphomas. Daratumumab, as I told you, is used for multiple myeloma. All these are monoclonal antibodies, and these are called targeted therapies. Targeted therapies means when we use the drug acts only on the target and spares the normal cell. Therefore, the side effects will be very, very less. Trastuzumab and pertuzumab are common and popular drugs in breast cancer. PDM1 is a special monoclonal antibody which will have a small dose of chemotherapy drug also. So when this monoclonal antibody finds the receptor, it not only acts by blocking the receptor and giving the treatment as target therapy, it also releases a small chemotherapy drug which is inside the antibody combination. So side effects also will be very minimal, unlike vomiting, febrile neutropenia, and severe weight loss which we see in chemotherapy treatments. There will hardly be any side effects, and the side effects will be mild fatigue, pruritus, nausea, slight altered oil habits, rash, and constipation. So these are all small and minute side effects which we see with targeted therapies and immunotherapies. This is an example of head and neck cancer where I used chemotherapy, a strong chemotherapy with Keytruda, that is pembrolizumab immunotherapy. And this patient, after 2 cycles, this was the lesion inside. This is a response rate. So such kind of responses we get when we use a strong chemotherapy plus or minus more immunotherapies. And this patient was taken up for surgery. It was inoperable upfront, and after 2 cycles, it becomes operable. So such will be the effect of chemotherapy and immunotherapies. So these are all examples of imatinib is a popular drug which we use in chronic leukemia, as you all know that. And sunitinib is used in renal cell carcinoma, sorafenib in hepatocellular carcinomas, regorafenib in colon cancer. And these are all multiple drugs. Ibrutinib in chronic lymphoid leukemia, acalabrutinib in chronic lymphoid leukemia. So, similar, I finish next 2 minutes. Similarly, even in radiation oncology, like Avinash was talking about, there will be targeted therapies. For example, a technique by 3D-CRT or conventional radiation is like chemotherapy. They destroy the cancer cell as well as the normal cell when the radiation is given. And there are many updated treatments and upgraded treatments now, which are called IMRTs. Intensely modulated radiation therapy, or VMAT, volumetric arc therapy, or something called image guided radiation therapy. But these and SRS, stereotactic radiosurgery, which I have just spoken about. But these are all updated and targeted therapies. So the radiation is given to the required area where the target treatment has to be delivered, and the surrounding normal tissues are treated. So the more the technique of, the better the technique of radiation, the lesser will be the side effects. So all these IMRTs, VMANs and IGRTs we have in our hospital, even our contemporary hospitals in Karimnagar also, they don't have these IGRT techniques. So IGRT technique is the first of its kind in the entire northern Telangana, other than Hyderabad. For example, if we talk about something called stereotactic radiosurgery, for example, if you have a lesion in the pons, suppose you have pontine glioma, or you have a lesion in the cerebellopontine angle, for example, an abortion sarcoma. It is very difficult to approach those areas and take a biopsy. So what we do is, these lesions will be provisionally taken as malignancies unless proved otherwise. So these CPI tumors or apoptotic gliomas, they can be directly irrigated with SRS, stereotactic radiosurgery. So stereotactic radiosurgery is nothing but delivering an accurate and good dose of radiation to the required area, minimizing the side effects, minimizing the radiation to the surrounding areas, and minimizing the side effects. So that is what we do with SRS, IGRT, VMAT, and IMA. So all these techniques we have in our hospital, first of its kind. So SRS, IGRT are the techniques these days. For example, we are treating breast cancer, left side breast cancer. We have the heart behind the chest wall. And when we try to irrigate the chest wall, MRM, the breast remote area, the MRM area, tumor bed area, when we try to give radiation, even the heart gets affected. Already I would have given chemotherapies and probably made the heart weaker. So if I give conventional radiation or 3DCR, the old types of radiation, even the heart gets affected. So what we do is we give a technique by name IGR. And we use further techniques called deep breath holding techniques. So when we give IGRP, what happens is only the area which needs to be irrigated will be irrigated, and the extra non-required areas, non-cancerous areas will be spared. So such kind of, for example, we are dealing with a rectal malignancy. The surrounding area is a bladder area. So sensitive area. When we irrigate with the conventional radiation, even the bladder gets affected, the patient will have cystitis. Suppose we are talking about cervix cancer, cervical cancer. What do you have besides that? You have bladder as well as rectum. So when I irradiate the cervix with the conventional radiation, what happens? The patient will have proctitis, radiation proctitis, radiation cystitis. So I have to use a technique which prevents the radiation to the unnecessary areas. Same thing with head and neck. I have to prevent irradiation to the submandibular gland, to the parotid gland, to all the salivary glands. I have to reduce the irradiation to the spinal cord. So what I do is I give a radiation which gives irradiation only to the required area and minimizes radiation to the surrounding areas. So it is again nothing but something called target therapy, like I spoke in medical oncology. So likewise you have in radiation oncology also. So these are all the updated treatments in medical and radiation oncology. And there are many other fields in oncology which you have to know: the surgical oncology, medical oncology, radiation oncology. And there are three main allied subjects to oncology: that is pathology, that is surgical pathology, nuclear medicine, and interventional radiology. So these three fields are also very much required for oncology, and we have all the three fields. We have in an interventional radiologist in our hospital, we have a nuclear physician to give PET reports and to give radioactive therapies of thyroid cancers. We also have an in-house oncopathologist in our hospital. So these allied branches also are very, very important, and so that the job is done in one place and justice is made to the patient. Targeted therapies are being developed in multiple cancers. As of today, targeted therapies roughly are available in 70 to 80% of cancers. And it's not that all targeted therapies will do great justice in all the cancers. In few cancers, targeted therapies will help the patient very well. In few cancers, they will be only nominal drugs, to be very frank. So we advise the patient accordingly, according to their financial status, according to the benefits. Sometimes what we see the patient status. He can spend some amount. So what I advise is you have to spend the amount judiciously. That means you have to spend on your dying father. Supportive care is more important than immunotherapies. Supportive care is, in the death phase, in the death bed, helping him die. Spending more money on a dying patient, putting him into coma, giving him strong painkillers, giving him some infusions in the hospital, giving him some anesthetics in the hospital, putting him into coma. So sometimes these become more important than immunotherapy or antibiotic, which are expensive. For example, if I talk about immunotherapy, it might cost anywhere from 1 20,000 also. So sometimes I ask the patient not to spend on immunotherapy in a dying patient. I ask him to spend on a smoother, for a smoother death. So it's not that all monoclonal antibodies or all target therapies are helpful to the patient. It is available in almost 70% of patients, and roughly I can say they are very beneficial in probably 25 to 30% of cases. ALL, there are few developments going on. AML, there are few developments. In chronic lymphoid leukemia, just like I told you, ibrutinib and acalabrutinib are very popular drugs, which give amazing response in chronic lymphoid leukemia. In CML, these are landmarks. Imatinib has come into picture 25 years back. It has created a revolution. And then the drug by name nilotinib has come into picture, dasatinib, ponatinib, bosutinib. Many drugs have come into picture. So target therapies are in CMS, CLS. What happens in ALL and AML, they are like, those cancers are like tsunami. So the very aggressive nature of those cancers will not allow the doctors or the scientists or innovators to create a drug which is going to act very slowly, like an antibody. There we have to attack the cancer like how it attacks the patient. I have to attack the cancer with a nuclear bomb. That is a strong induction chemotherapy. So it is like a nuclear war. There is no time for the patient or me to, target the patient. Rocket missiles launch, it has to be a nuclear bomb. So it has to be an induction chemotherapy which is very strong, which happens in acute lymphoid leukemia and acute myeloid leukemia, where it is very unlikely for any target therapy to come into picture.
Earliest method of detecting ovarian cancer, the word goes to CA125. It means that routinely we do not do CA125 for detection of any ovarian cancer. The first thing is clinical examination of the patient, age of the patient, suspicion of the patient is very important. The most important thing is that ultrasound abdomen, that's a transvaginal ultrasound abdomen, should be mandatory done. In any case, you suspect a carcinoma of the ovary. The basic thing what happens, an ultrasound abdomen is done. But the thing is, this transvaginal ultrasound abdomen, it has to be done, and in conjunction with CA125 and some tumor marker, we can calculate diagnosis. Based on the size of the lesion, if the patient is postmenopausal, the size of the ovarian mass is more than 6 centimeters. Solid cystic lesions are there. And you see your vascularity, the Doppler flow is more. And patient is having history of loss of weight, loss of appetite, the systemic complaints. All these things should be taken in when you are suspecting an ovarian malignancy. Just by saying CA125 elevated, you don't have the diagnosis of carcinoma of ovary. In patient, postmenopausal patient, if the CA125 is more than 200, then we can suspect that this is a case of ovarian malignancy. And one more thing is that diagnostic laparoscopy also plays a major role in detecting ovarian malignancy, especially postmenopausal women. Patient comes only with history of ovarian mass or ovarian cyst, nothing would be there. Patient will have some symptoms of loss of weight and loss of appetite. And when you see, you have on ultrasound, there will be mass 5 or 6 centimeters. Immediately, patient will have what to do. Then the immediate thing should be, you should go for a diagnostic laparoscopy. Diagnostic laparoscopy. Look what is the pathology of the ovary. And in most of the cases, when the patient comes to the hospital, 80 to 90% of the patients they have hysterectomy done. So most of the cases, what we see, we have a unilateral ovarian cyst patch. But it's a large ovarian cystic lesion. The next thing what we have to do a diagnostic laparoscopy, see if the size is more than 6 or 7 centimeters. And if you are predicting a malignancy, then we can take a biopsy. Or else, let's convert it, do a staging laparotomy, remove the ovarian cyst, do a intracolicectomy, do a proper staging therapy. That is what we regularly do.
In the case therapy, I have to give 2 seconds of chemotherapy more. Now, what happens in early tumors is usually a patient with ovarian mass more than 40 years or 45 years, perimenopausal or postmenopausal lady. If you see an ovarian mass and solid cystic mass, you should not do an ovarian cystectomy directly. You have to open it. If you have a facility for frozen section, whatever surgery you are doing, cystectomy or oophorectomy, send it for frozen, confirm it is not malignancy, and you can leave it over there. But if the frozen shows it is malignancy, you have to complete the entire surgical stage, which includes the removal of upper ovary, the tubes, the uterus, the entire surgical stage process. So, frozen section plays a very important role in that suspicious case of malignancy. CA125 may have a role, may not have a role. The CA125 is sky high, say 1000, 2000, 5000, there is no other doubt. It is definitely malignancy. If your gut says it is definitely malignancy, go ahead with complete surgical staging and close the case. But if the CA125 is borderline and you have ultrasound findings suggest malignancy and a CT mass in the abdomen, please go for frozen section, confirm it is malignant or not, and act accordingly. If it's a young patient, always do not forget to do a marker, that is AFP, beta, HCG, and LDH. If the markers are sky high, it's straightforward case of germ cell tumor, and accordingly, whether the patient has completed their family or not, accordingly you have to act and spare the uterus or spare under ovary, remove that affected ovary and act accordingly. Sometimes even the tumor markers may be normal in a case of dysgerminoma. In a case of dysgerminoma, again the frozen section comes into picture. Get a frozen section, confirm it as malignancy, remove the affected ovary, and confirm whether the patient has complete family or not, and accordingly you spare the ovary, spare the other side of the spare the other ovary, do the surgical staging, take multiple biopsies from different areas. So it all depends on multiple factors. So whether we are dealing with a young patient or not, or an older patient, whether it's a prime malignancy case, whether the CA125 is high, sky high. Many times we see, not many times, in few cases we see granular cell tumors, circularly cell tumors. What will be there? Because the tumor markers will be negative, CA125 will be negative, the LDH, AFP, beta, HCG may be negative. So you have to do something called serum inhibition. And granular cell tumors are usually how the patient comes to us. They don't come with the total abdominal hysterectomy or bilateral salpingectomy. They come with ovarian cystectomy. So when ovarian cystectomy is done and granular cell tumors are approved, what I have to do is I have to take into few other factors into consideration. The mitotic index, the size of the tumor, whether the ovary was ruptured intra or whether the ovary was ruptured after the surgery is over. So all these things have to take into consideration and decide whether the patient has to get chemotherapy or not. Because granular cell tumors grow very slowly. Suppose if I am dealing with a 60-year-old person with a 6 centimeter mass and the capsule is intact, I won't give chemotherapy. So I take this as an early case. Suppose I am dealing with a 40-year-old case, a huge mass, ovary is intact, high mitotic index, I will give chemotherapy. Because the patient might get the tumor if I don't give chemotherapy in 3 to 4 years. I give chemotherapy in 8 years duration. So treatments depend on multiple factors. So it depends on young patient, old patient, histology, many others. So did I solve your question? Yeah.
I think most of the cases of ovarian malignancy they land with the gastroenterologist because most of the patients they come in with still dyspepsia. Apart from that, we don't have any other symptoms. So there is no other investigation to prove that you can detect ovarian cancer clearly. The most important thing is routine ultrasound after post-menopause 40 routine ultrasound that will be there. But there are no proper guidelines as such for detection of COA. We have only 2 screening investigations, that is for breast cancer and cervix. These are the guidelines for the double. Apart from that, we don't have any guidelines. Screening of ovarian cancer.
Sir, if a cancer is found to be stage 3C, and if the patient has to get ascites, you will never be able to get it early. It is not that the patient will have to go through a phase of phase 1, stage 1, stage 2, stage 3 and 4. The patients might directly go into stage 4. It all depends on the tumor genetics. So if the patient is bound to get stage 3C cancer, they get it. There are no phases as 1, 2, 3. Very rarely, we get to see a tumor in the ovary, and if we neglect it, then it might go into stage 3. So in that case, ultrasound is very important by a good serologist. CA125 might help you, and a high index of suspicion and correct way of approaching the case, like I said, approach section. So that those approaches might help in detecting the case early. But if the patient is bound to have stage 3C disease or stage 4 disease, they'll have it. That's we cannot find it early.
Yeah, carcinoma colon we regularly have after 40 years the routine we do colonoscopy every 5 to 10 minutes. So as a part of this new guidance, in part of UC, few of the centers they do colonoscopy every 5 years, and few of the centers they do colonoscopy every few of the first years. As in India, we don't have any guidance. Or else they do a FOB, fecal occult blood test, to know whether there is any blood in the stools. So in USA, where they take this fiber, colon biopsy is very good. So routinely they do colonoscopy and sigmoidoscopy as a part of routine screening. And one more thing is that recently they have got this narrowband imaging in the same scope is endoscopy, colonoscopy. We have what is called this narrowband technology. So with narrowband technology, we can easily detect malignancy. Even if you have a polyp, if you don't take a biopsy also, with the narrowband imaging technology, we can know whether the polyp is benign or malignant just without a biopsy also. So narrowband imaging is coming into the market at a higher pace. So now most of the Japanese people, what they are doing the research is that without doing the biopsy, whether we can know whether the lesion is malignant or benign. But the data has not yet come. Maybe in the future, without biopsy, also we can detect whether the polyp is a benign or malignant lesion. So, really, as in India, if the patient has symptoms of any colon, maybe if he has constipation, loss of weight, diarrhea, then you can advocate them for colonoscopy or sigmoidoscopy. And the family history of malignancy also. If you see people with history of colon cancer less than 40 years, you have one or two people suffering. If you ask the patient, they say their father, there is somebody who is suffering from colon malignancy. Then routine colonoscopy can be done. Or family history of familial adenomatous polyposis. In fellow, when we do a colonoscopy, has multiple polyps. Then we should ask the patient to get screened with his brother, right? In the same sibling history also. So that is what we are doing.
Basically, approved and popular screening methods are for breast and cervix. Mammography, pap smear, self-breast examination. These popular. Otherwise, the CMPSA guide, digital rectal examination, EV, colonoscopy, and low-dose CT test for lung cancer. It was unpopular, and usually routine based complication are. What came out doubts in our families symptoms, Avinash symptoms, we ask for colonoscopy. So colonoscopy is the best for rectal malignancy.